also prepared a presentation on chloride diarrhea, and Stephanie prepared a presentation too on mosaic trisomy 10. So there's going to be a lot of genetics. Be patient, and you guys are gonna learn so much. Exciting. Yes.
You're gonna go first?
Stephanie and Claire, do you want Kavisha to go first, or would you like to go first?
Happy to do whatever.
I'm happy to go first. I have my slides up.
Okay, go for it, Kavisha, then. Go for it.
Okay. So today I'm going to give a little quick presentation on Fibrodysplasia ossificans progressiva, given that we recently had this patient who had presented with this and was ultimately delivered yesterday. I did get this actually talk to the residents yesterday too.
That's amazing.
So it ended up working out and was very timely. Okay, so.
Go ahead.
Okay. So I just wanted to start off, since everybody here probably knows at this point that I love history and love going through the historical descriptions. FOP, interestingly enough, was first described in 1736 rather, in a letter to the Royal Society of Medicine by John Freck of St. Bartholomew's Hospital in London, where he saw a patient. There came a boy of a healthy look, about 14 years of age, to ask us at the hospital what should be done to cure him of many large swellings on his back, which began at 3 years since, and have continued to grow as large on many parts as a penny loaf, particularly on this left side. They arise from all the vertebrae of the neck and reach down to the os sacrum. They likewise arise from every rib of his body and joining together in all parts of his back, as the ramifications of coral do. They make, as it were, a fixed bony pair of bodice. And I wanted to include this description because I felt like it was a really beautifully portrayed visual of what FOP looks like in patients. So interestingly enough, this is actually a picture of one of the most famous patients with FOP. And this patient, Harry Raymond Eastlack, was born in 1933 in Philadelphia.
Oh my God!
He died of pneumonia in 1973, just days shy of his 40th birthday, in fact. And his skeleton, if you guys are interested, and maybe we can do a field trip as an MFM group to the Mutter Museum.
I think I saw it.
It's very, very famous. And it's actually one of the most well-known FOP skeletons that exist in the world. So what's interesting is that if you look at a normal skeleton, it collapses, and you have to put it back together with wires and glue. So a normal, like one of our skeletons, for instance, would have to be put together with wire.
100 years, hopefully.
Yeah.
For you, the young people.
I hope not to live that long. In the case of Eastlack's skeleton, however, most of his was actually fused together because of the heterotopic ossificans. And so what ended up happening is that it's mostly a one contiguous piece with sheets of skeleton that formed from his flare-ups with FOP. So this picture right here depicts Eastlack at 25 years old, and this is his skeleton at 39 years of age. So what is FOP? FOP is a very rare genetic connective tissue disorder characterized by the organization of heterotopic hard tissue within the soft tissues such as ligaments, tendons, and skeletal muscle. The tissue formed in patients is not just mineralized calcium phosphate, but it actually resembles newborn formation by osteoblastic cells via the entire endochondral ossification process. And it's very, very rare. 1 in 2 million people worldwide will have this, and it is not determined by race, gender, or geographical distribution. So I wanted to go a little bit in depth about the clinical features, what you expect to see. And at birth, the most common pathognomonic thing that you will see are malformations of the big toe. And 50% of individuals will also have malformations of the thumbs. So what you see is a shortened great toe with a malformed distal first metatarsal, and it's typically missing. So that's why yesterday when we had the neonate was born, the first thing that the husband of the patient asked for was, were the toes normal? Which they were.
Yeah.
What ends up happening after is typically in early childhood, you see progressive bone formation in connective tissues. So you have, again, this heterotopic ossification, and it typically follows soft tissue injury or viral illnesses. You have firm, tender swellings on certain parts of the body, with tissue eventually maturing through a cartilage to bone pathway, which is depicted here. I didn't go into detail about this. I know we did this through med school, but
Yeah.
Is the theory that like in
Inflammation.
utero the feet and hands are like the most active and so they're like damaged or inflamed? Like why is it?
I don't exactly, and I don't think they know because
the big toe.
Yeah. There are many genetic disorders where actually, this is not the first disorder where the toes are affected. Many of the syndromic.
can be 50%, but it's typically the big toe. So it's typically the first metatarsal toe.
So this does apply. The toes and the thumbs, can be the main manifestations of a lot of genetic disorders, specifically some of the canosynous disease. I can show you pictures.
Yeah. And I suspect it has to do something with the bone morphogenic pathway, but I don't know specifically how or why. But it is something I think, it's hard and something that we don't consider necessarily looking at when we're doing ultrasound, but that would be the thing to look at.
We look at toes, to be honest.
No, I know, but it's like sometimes like it's so hard because it could
it's
just be a malformed big toe and it's not necessarily missing.
Yeah.
But the main thing to know is that the ectopic bone growth involves tendons, ligaments, skeletal muscle tissue, and connective tissue such as the fascia and aponeurosis. In many cases, pain and stiffness occurs in those areas. And so what you can have is a low-grade fever with the swelling that's associated. Then the swelling starts to regress, and then that swelling, that area, hardens and becomes bone.
Inflammation.
In terms of what ends up happening as this disease process continues, the neck, back, chest, arms, and legs are first the areas that are affected. Eventually, the hips, ankles, wrists, elbows, shoulders, and jaw, as in addition to the abdominal wall, is affected, and that's something to take into consideration. If you're affecting the jaw, what that means is that you're not able to speak. So a lot of these patients then lose the ability to open their mouth, to eat, to speak. Eventually, you have complete immobilization, not mobilization, but immobilization, and you become susceptible to respiratory infections. So what we find is that often most of these patients end up dying of a respiratory illness, similar to the patient that I had discussed earlier.
Yeah.
They may also develop right-sided congestive heart failure. And then also, if you think of ossification, you also think of the ears. So most patients also do end up having hearing impairment. Now, what's interesting is that the progression of the bone development could be rapid, but it could also be gradual. And they've actually done studies in twins specifically, and what they found was that in one twin, it may be a rapid progression, but in the other twin, it may in fact actually be gradual, which tells us that there's also environmental factors that are important in coming into play.
Or other genetic mechanisms.
Or other genetic mechanisms.
For the phenotypic expression of disease.
Right.
And basically, you have mRNA, right? You have
microRNA expression.
mRNA, you have methylation. So all of these things are going to play a role in the expression of that particular gene. Good, thank you.
So radiographic features. X-ray and bone scans are often done, and they can show normal remodeling of heterotopic bone with fracture healing accelerated. So interestingly enough, having FOP does not increase your risk of fractures, but if you do develop a fracture, the healing process is accelerated with heterotopic bone formation. You can do CT and MRI imaging. However, it does detect earlier lesions, but it's considered to really be a superfluous test. And so the main way to definitively diagnose FOP, it is first a clinical diagnosis followed by genetic testing. And this image right here, the radiograph of the feet, and you can see that there is a missing first metatarsal. I also just wanted to take a moment to look at the histopathology because I do think it's also interesting to take a look and see if we look at our control skeletal muscle, we don't really see any ossification versus this is a FOP muscle where we are able to actually visualize directly that ossification that is seen, that we would expect that bone tissue is now in the muscle. Genetics. So we have multiple, the genetics of FOP is interesting. So there's different versions of FOP. The classic FOP is actually due to a recurrent activating mutation, so essentially a gain of function mutation in chromosome 2, specifically for the gene ACVR1, which encodes for activin A receptor type 1, activin-like kinase 2, and it is involved in the bone morphogenetic protein pathway, the pathway that, in other words, regenerates bone, so the osteoblastic pathway. There's also an atypical FOP patients, and the gene that's typically associated in those patients is heterozygous ACVR missense mutations, which is essentially a point mutation that can result in a codon that results in a different amino acid. Now, most cases of FOP are sporadic, but a small number of inherited FOP cases actually show germline transmission in an autosomal dominant pattern. So we're seeing, again, classic Mendelian genetics come to play. Now, how do you manage these patients? So medical intervention is currently supportive. You can give NSAIDs, COX-2 inhibitors, leukotriene inhibitors, more for symptomatic improvement and management. Steroids are often what's used for symptomatic flare-ups. In terms of surgical management, it's really not recommended, and the reason is when you do surgery, you produce more trauma. Trauma then induces heterotopic ossification. So there is a very high risk of introducing more trauma with surgery, so typically it is not effective and it's not recommended. Now, what does this mean in pregnancy? So it is extremely rare among persons with FOP and poses unique maternal and fetal risks. This includes heterotopic ossification with rapid progression of disease, worsening pulmonary status, and this is because of the progressive thoracic volume reduction that undergoes in pregnancy, with limited chest wall compliance, again with a gravid uterus, spontaneous abortion, preterm delivery, cesarean birth, VTE, wound formation, 50% risk of fetal inheritance, because again, it's an autosomal dominant trait, and maternal fetal death. Now, there are only 5 instances of childbirth among patients with FOP that have been described in the literature. 5. What they have done in those 5 cases,
And are we number 6?
we are number 6,
Okay.
is the management. So this is what they do. And I'll talk a little bit about what that means too. So management, steroids must be administered in the event of anticipated delivery. And I put preterm, but really delivery in general. And this is due to the risk of FOP flare-up associated with IM injections. And that's why we spoke about that at extensive length. Steroids should be administered orally instead of intramuscularly. FOP flare-ups, again, in pregnancy should be treated with corticosteroids. In terms of delivery, vaginal delivery is contraindicated in patients with classic FOP due to pelvic deformity, hip contractures, or ankylosis and spinal fusion. And cesarean delivery is therefore the modality of choice. But again, we're doing surgery, we're introducing trauma. There is potential for heterotopic ossification to occur at the incision site.
Sorry.
I will go into our patient like very extensively. This is just the 5 patients, and then I'll go.
The answer later on, but go ahead.
No, you were gonna say it, that's fine.
The indication of the vaginal, the delivery is because the patient already had a malformation of the pelvic bone and hips contractures and ankylosis and spinal fusion. But what if the patient don't have those things?
I will absolutely get into that at the very end. Anesthesia. They are typically not candidates for regional anesthesia due to fusion of the lumbar spine, hips, and sacroiliac iliac joints. Needle insertion with attempting an epidural spinal may also precipitate heterotopic bone formation and absolutely should be avoided. In terms of intrapartum and postpartum, patients should be carefully positioned with the assistance of additional padding to prevent pressure sores and neuropathy, which is what we did in this patient. Due to the risk of disease flare-up associated with surgery, prophylactic prednisone at a dose of 1 to 2 milligrams per kg should be administered at the time of delivery for 3 days postpartum, and post-operatively, patients should receive anticoagulation, interestingly enough, with low molecular weight heparin due to the risk of VTE. Typical obstetric complications, again, in the 3 patients that have been depicted in the literature. Postpartum hemorrhage. The patients that are described do undergo general anesthesia. Uterotonics can be administered, but again, avoid IM. Preeclampsia. Now, this is what I found to be actually interesting. So there's no link between FOP and chronic hypertension, but the gene that is associated with FOP is also associated, has recently been implicated as a potential genetic precursor to preeclampsia.
Do we know why?
No, we don't know exactly why, but it's interesting that it's the
about
same gene.
atherosclerosis, calcification of the arteries, and hypertension.
Yeah,
But that's hypertension chronic. And
but it's interesting. It's not specifically chronic hypertension. It's specifically preeclampsia. They did not find an
But
association.
this is what we probably know. you
Yeah,
know.
yeah.
Research is probably limited.
Right, research is still developed, but this is interesting. And then FGR, there is a potential link with FGR due to the space limitations of fetal growth secondary to abnormal wall ossification or chronic hypoxia associated with restrictive lung disease. Here is a summary slide,
You should have done a biopsy, but then you don't want to do a biopsy.
because you might induce more trauma, so it's really, really hard. There are 3 cases that were actually written up by Dr. Kaplan at Penn, who is the leading expert in the world for FOP.
Who was with us at the meeting last week when I missed, the hour here.
So these 3 cases were actually very interesting. They were with classic FOP specifically, all of which had severe restrictive pulmonary disease. All delivered preterm, the first at 25 weeks and the other 2 at 34 weeks. 2 of the deliveries were via classical C-section. All underwent nasotracheal fiber optic intubation. All had postpartum hemorrhages. All required blood transfusion. And then in case 2, myometrial calcifications were actually noted during the hysterotomy repair in the uterus, which is interesting because it's a smooth muscle and we expect this to see it in skeletal muscles. And 2 of the 3 patients ended up developing preeclampsia with severe features requiring magnesium.
What they were delivered preterm? What they were delivered preterm?
So the first one went into labor.
Okay.
The second one, PPROM to 34 weeks. And the third one was because the patient was having increased or worsening respiratory status, so they decided to deliver at 34 weeks. In terms of neonatal complications, only 1 was found to have FOP because of the toes. So this is normal toes, normal feet. Abnormal toes, this is what you think of when you see FOP.
The previous pictures are baby?
No, I didn't take a picture of the
wonder if it was
baby.
detected.
They were normal, they were like
They
this.
looked like that, they looked
They
like
were
that.
like that.
I wonder if those were detected prenatally,
Yes, you should be scared.
They were not detected prenatally.
like in that X.
Oh,
This one was
maybe,
not detected prenatally.
maybe they did not look for it because they didn't do the literature review that you did.
But it was not detected prenatally. So now I'm going to talk about specifically our patient JR, to maybe discuss some of the questions and concerns that have been brought up. So patient JR is a 33-year-old G1P0 at 38 and 1 who has FOP followed with Dr. Kaplan. She was diagnosed with gestational hypertension on 4-9. On 4-5 had a growth scan, 259 grams, 9 percentile with normal umbilical artery Doppler. I wrote that correctly with a capital D, no S's. She underwent a prime C-section yesterday, received IV Solumedrol, received IV TXA and mesorectally, had a McGrath video laryngoscope for intubation. Baby was 5 pounds, 11 ounces, which is exactly her weight at birth too. With APGAR of 3 and 6, EVL was 1362, and yes, tap blocks were administered at the end of the case, which was interesting.
Why would
Which
you be
was
like,
very
I'm gonna give the Solumedrol IV, but here's a lidocaine. Like,
And
that's crazy.
Well, and also like I'm gonna use a scalpel across I still don't understand the section thing.
So we're gonna actually go into a little bit about that. So in terms of her family and personal history, so the mom's symptoms are mild, which was what led to a clinical diagnosis and genetic diagnosis of FOP later in life at the age of 41 years old. She then underwent DNA sequencing and found and had an ACVR gene. She was heterozygous and had this variant that was associated with very mild, non-classic FOP phenotype. The patient and her brother and the mother's dad underwent testing, and they were found to all be carriers of this familial ACVR1 variant. The patient is currently at this moment asymptomatic. So what does this mean? Interestingly enough, Dr. Kaplan wrote about this patient and her family in an article and went through all the symptoms. So here is a family tree that we are able to see what symptoms the patient had. So I'm gonna actually start off with not the patient herself, but the patient's mother, who really is the progenitor of this. And so at age 14, the mom, she developed soft tissue swelling and decreased range of motions at the temporomandibular joints. She gave birth to 3 children via vaginal delivery in her 20s. At 29 years old, she developed soft tissue swelling in the left rhomboid musculature. And then she actually started to have swelling and symptoms like throughout her entire pelvic, so ossifications in her entire pelvic girdle, where a patient where we would deliver, and so has now had significant lesions that are in that area. At 38, this was at 36. At 38, she developed a large baseball-sized submandibular swelling, had steroids.
So is it normal for it to be that delayed?
No, because this is a mild different variant. This is a completely different.
She's lucky.
Yeah.
So the patient basically
This is
1 in 2 million.
Decade.
This is this patient 1 in 2 million is to have FOP.
Right.
Of the FOPs, this is the rarest of the
This
rare.
is like 2% of the FOPs will be like that.
So she had 3 pregnancies, 3 vaginal deliveries, and now
Is
they
having
think that
issues.
because of her deliveries. She
Might be having
pelvic
symptoms,
problems.
correct,
Yeah,
and
calcification.
so
What
that.
about intercourse? I'm sorry.
Well, yes, no, we asked about that. We were actually, so
But
that's the
also-
things that we brought up.
Same
Then
as
it's 3 C-sections, 3 vaginal
Yeah.
deliveries, pick your
the
poison.
thing is,
all of that.
the trauma may not be the delivery, but the pregnancy itself. Like an incontinence cases,
Was she told to
the
get a
pregnancy
surrogate?
is the reason for some
Was she told
problems.
to get a surrogate? Was she counseled to use a surrogate? I mean,
She could,
hello.
Yeah.
I mean, people can't afford a surrogate.
She did IVF.
So that's cheaper than a surrogacy.
I'm just
Surrogacy is
saying,
$200,000.
Your body versus paying for a surrogate.
So that's a question, I don't know if you had the answer, is this pregnancy related or delivery related?
It's so hard to even,
I
this
think
is,
it's gonna be
such-
both.
It's probably both, but it's so hard to say which is which.
Because pregnancy,
we
you know,
also
all the
only have,
inflammatory markers are in the sky.
We also have an
just
N of
related to that.
1,
Yeah, this is.
and this is N of 2 with this specific variant.
So could you go again telling us her pelvic symptoms?
Not our patient, her
No, the
mom.
mother,
Her
the
mom.
Her mom,
Yeah.
so she has heterotopic ossifications in bilateral hips, and her sacral iliac joints.
Oh my goodness.
So that's her pelvic findings?
Yeah, is she obese? Another problem that could be.
I'm gonna be honest with you, so basically, we are talking on this end, honey, when you deal with these patients, you should see how passionate Kaplan was, how much he's scared, you know?
So the recommendation, because Kaplan's been studying this literally his entire life,
She came to us already with this too.
right. I think when she was first seen by us 2 years ago, was here for a genetic counseling visit. When she came and was pregnant and had been seen for an initial consultation, was actually like cleared for a vaginal delivery. It was ultimately the conversation that she had with Dr. Kaplan, where the only cases that he has dealt with have been really FOP, classic FOP patients. So we treated her like a classic FOP patient, despite the fact that she's asymptomatic, to decrease, I think it was basically a risk-benefit ratio of like, hey, like you could develop symptoms here, or you could also have symptoms on your abdomen. What would you prefer? And this is what we know, this is what's been done, this is what the pregnant patients who have delivered and what their outcomes have been. And that essentially was a conversation that was had. The patient then, after all this information, decided to proceed with a prime C-section.
Is the mother alive?
Mother's alive. The mother's dad passed away at the age of 72, but not of heterotopic ossification, but of actually Parkinson's instead.
And just wondering about her functional status growing older, walking.
Mom, it sounds like, I think, does need assistance with walking, is my understanding from what again, I took all this information from the case reports, and that's what.
Okay.
And that is it.
I mean, there is always going to be the question about what really caused the trauma, because when you have the uterus package, which is what I call, it could easily be 10 pounds, 12 pounds at the end. She had a 5-pounder plus amniotic fluid placenta uterus on the pelvic floor every single day. That causes trauma, stretching of the muscles,
Yeah.
breaking downs, things like that. Plus, walking, rolling, running up and down during your life can also injure your joints. So
Yeah.
it's not pregnancy. I wonder, is there a male case?
So she has 2 brothers, and her brothers also have the variant. They are younger than her. The youngest brother has developed knee problems.
Let's see, it's.
And the
I want to
patient
know
has a
how-
brother also.
No, the patient
No, but-
has 2 brothers.
No.
Yes.
And
And they
one
are
of them is
affected.
fine and doesn't have any symptoms. The other has knee issues right now.
So I would like to know if there are male cases, the full effect, and how do they grow older? Because they're never going to be pregnant, but they still probably are going to end up with sacral joint deficiencies, hip problems, knee problems, ankles. So the pregnancy has nothing to
So
do
they
with
do.
it.
Amanda, it's gonna be difficult to convince.
Well, I know.
It's gonna be almost impossible to convince these people.
Well,
you
you
know?
need the evidence. Where are the evidence?
There's gotta
based
be-
people?
I mean, the issue is that there's
There's no
only
evidence for
5
or against.
patients with this.
Yeah,
and
but that's what I'm
and
asking.
then
Are
when
they?
we're looking at the other patients, like the men, like they do develop like the hips are the second thing that's affected.
Yeah,
The joints are affected. In this,
No
it's
matter what you
interesting
do.
because you have to look at classic FOP and compare it to now this variant. The issue with this new variant, it's only studied in 2 families, with her being one of those
Yeah.
families. The other family
Time will tell.
is like we just don't have the information.
But this is
And-
something for when the next case shows up, something like how the males look like with
one
this
individual.
variant.
Well, but I think what's
There's
actually gonna be more
guys.
important is to follow this patient.
Yes?
Think about how many
did you
people
listen?
probably have this variant and we just don't test for it because no one in their family has symptoms. It's probably much more common than we realize.
It probably is, yes. All these people who complain of pain and nobody pays attention.
I'd hate to put them all to sleep and give them primary sections.
Honestly.
I don't know if I should get tested.
No. Okay,
Interesting, okay.
did you see the fabulous presentation Kavisha did?
Yeah, great job, Kavisha, thank you.
Yeah.
Incision with the
O.J.
scalpel.
Simpson died, guys.
I am kind of sad that we put her to sleep.
Insane.
Sorry.
Everybody goes to sleep. Jefferson they operated on like 100 FOP patient.
I didn't know we were a referral center for FOP.
There's very.
I know.
Jefferson is a gem for many things, by
She
the way.
would attempt a vaginal delivery, her only method of anesthesia would be like nitrous.
Or IV,
I
Denon
mean,
or
yeah, but you
something.
have a limit on IV, right?
Yeah.
So
Yeah.
it would have to be nitrous. That's another
And then-
consideration.
Yeah. So I just wanted to make sure that I let everybody know. So as you could see, like this patient has been at Penn for years. Her entire family had been at Penn for years. But, you know, someone contacted the dean here, the dean contacted Bill Schlaf, so Bill Schlaf referred her over to us so that I can see her. So this means a lot for me to continue his legacy taking care of this patient. And sadly, yesterday, you know, when I saw her post-op, she said, the husband said, well, we're so happy Dr. Schlaf referred us to you. I'm like, I didn't tell them he died.
Wonderful case, thank you.
Kavisha, that was amazing, and
You ran the.
But what regional would it have been?
yeah, because you can have fusion and then calcification.
But she's no phenotype though. That's what.
But how would you know?
But growing
may
up,
express-
her mom has a lot
Listen,
of.
I was like you last week. They like she can have an expression of her disease at any point, and that can be true. Like her mom, she didn't express it until later.
The dad, I mean, her grandfather had very minimal symptoms.
Yeah.
So it just, again, environmental factors come into play.
Okay, so I guess
I
Sufsha.
guess you couldn't change Dr. Kaplan's mind about the vaginal delivery.
I think Dr. I
I
mean,
still don't understand the no injection, but can use a scalpel to do a fan
Or get vaccines with no issues.
Injection going through the
Yes, she gets
muscle.
vaccine.
Well,
You're ripping apart the
muscle.
muscle.
We
to
were
do a section.
we tried to be as-
Were you gentle with the? Were you gentle and meticulous with your?
I know, at that
Dissection?
yeah, we were.
Can I tell you something? I've never seen it.
abdominal muscles.
I've never seen it. I saw it yesterday.
Do you use Bovie? Do you use Sharp?
And the needle is like 10 size 10 almost for me.
Into the transverse abdominal.
I know, and I don't think the group from last week knew what tap lock is. I really don't. Because what's
We
his
did them in
name?
residency on everyone.
Everybody got tapped.
So basically, John Wenzel was like, okay, and please give us your approval for doing this. And they're like, okay, sure. I'm like, okay. And when I saw yesterday all the large needle going 1, 2, 3, I was like,
I had to actually walk Dr. Al-Quali out
She
of the
couldn't even
room.
have
Yeah,
like
no,
a
no.
pudendal nerve block if she tried like.
Doesn't make sense.
Yeah. Like literally.
I really,
Do you use
I'm gonna.
Bovie, Sharp? Like what you get like?
Yeah, we did
Dissection,
we did a
everything?
beautiful
Yeah,
C-section.
that'll be a good point, Bobby, because you injured the tissue.
I was
tunnel
wondering
injury.
why she hemorrhaged, but apparently this is like a thing.
Yeah, that's another thing, why she have hemorrhage.
Because she was a primary section, she lost like
General,
almost 1,500.
general anesthesia.
And it's appropriate because her hemoglobin went down to 7 now. Is she, 2 things, before we go to the next case.
Yeah, that's what I was saying.
Is she on anticoagulation? She's written, can we double check?
I have to actually double check, I don't know if that's, she should be ordered for actually
Can we check, and did we
anticoagulation.
order her steroids, whichever,
Steroids have been ordered,
and which one is that?
prednisone 100.
100 milligrams daily,
Daily.
for 3
For
days.
3 days.
I am.
Any issues with
Yeah.
blood transfusion?
No,
Any issues getting blood transfusions?
no, I don't think she'll have issues. Okay, that's good, thank you so much. And how was her bleeding overnight?
None.
No, okay, that's good. So hopefully she's gonna stabilize at 7. Can we reach out, can Julie Gomez reach out to Dr. Kaplan
I'll
today?
reach out to Dr. Kaplan.
To tell him, IV iron?
Yes.
Can we, is it okay? Because I don't want IV iron to be causing. No, this is
You
serious.
never know, yeah.
No,
I
I'm
will,
not
I
talking
will.
about.
Iron can make you turn into bone.
Well, iron is very
Okay.
plastic.
No.
Okay, sorry, I had to do that.
Listen, iron can deposit in tissues. Iron
Sorry, I
can,
had to.
that's a problem. Iron can deposit in tissues.
No, of course, yeah, hemochromin. I'm just like, give iron to everyone.
Plastic. It
Yeah.
burns like hell.
Kavisha, I
Just gonna
apologize.
turn into bone.
That you can.
Amazing job. You did such a great job just walking through the history and the pathology of the disease. Did you mention too that she, and I apologize if you did, she did actually have some minor surgeries in the past. I believe she had.
Yeah, I didn't mention that she had fibroadenomas of her breast, and I believe those were removed.
Yeah, so
I
there's,
looked at her incisions,
yeah,
and they were under general too.
right.
With naso.
Mhm.
Fibro.
Each time.
Yep, and I looked at her
Fiber optics.
paws, they were just a little bit wide, and Kavisha did an amazing tiny baby incision for her. Okay, Stephanie?
I can get started, and I apologize. My ear pods are not working, so if I have difficulty hearing you guys, you can put it in the chat. Let me see here. Let's see. I'm going to be presenting today on a case that we saw. Some of you might have seen her, this patient for a consult.
I've seen her 4 times for a consult only.
Yeah, she knows us very well and we know her very well. Can you guys see my screen?
Yes.
Okay, cool. So today we're going to be talking about the genetic evaluation of the fetal demise. The case, we're talking about patient CP, who's a 34-year-old prime who transferred care to Jefferson at about 20 weeks. With us, she had a normal anatomy ultrasound at about 20 weeks, and prior to that, normal cell-free DNA screening and MSAFP. At about 35 weeks, she presented to L&D due to decreased fetal movements, and unfortunately was diagnosed with the fetal demise. Workup was conducted, including amniocentesis for genetic testing prior to induction of labor, and amniotic fluid was initially sent for chromosome analysis. The family had also consented for a fetal autopsy, which was pending. So by the time that I became involved with this case, the KB had returned negative, ruling out fetal maternal hemorrhage. RPR was also non-reactive and UDS was negative. For APLS, she did have mildly elevated anticardiolipin and lupus anticoagulant. So because it was indeterminate, the plan was to repeat testing after 12 weeks. Chromosome analysis was normal and consistent with a normal male karyotype, and the final autopsy was still pending at that time. So as far as we did set her up for genetic counseling because of the normal karyotype, and the plan was to offer her further testing, including microarray. Nothing was there wasn't too much that was revealed from the genetic counseling appointment that could shed light on the demise. Patients of Ashkenazi Jewish descent. Her and her partner previously had expanded carrier screening. She was found to be a carrier of SMA, heterozygous for factor 11 deficiency, and a carrier of an Usher type disorder, which is congenital hearing loss and blindness. The partner had screened negative for these conditions, but was found to be a carrier of Joubert syndrome type 9. At the end of the consult, the plan was to proceed with microarray as we normally would. So the plan was to add that on to the analysis. The patient also had expressed that she was pretty motivated in finding an underlying etiology for the demise. And since we had amniotic fluid available, thought that she may be a possible candidate for Columbia's LawSeq genome study in the event that microarray and the APLS are unrevealing. So I'm not going to talk too much about the LawSeq, and I do want to heavily emphasize that not every fetal demise that we have at this point in time is going to be, samples going to be sent for the study. But just due to the nature of this particular case, it felt like it was a good fit. So we did proactively send cultures over to Columbia, and they graciously accepted samples prior to enrollment of the patient and extracted DNA since the cultures were starting to get older. But as far as inclusion criteria goes for the study, they will accept patients who had a demise after 14 weeks. Sufficient fetal specimen, amniocytes are preferred, and then of course the parent has to be above 18 years of age. And then exclusion criteria is effectively any potential known cause for a fetal demise, including. So microarray actually returned, and we were surprised to see, given the normal karyotype, that
Yeah, I think you have a fan making noises or something interfering with your sound. We can barely hear you.
Oh, okay. Hold on 1 second.
I think you have a fan. So standing to around and hear the blades.
Okay, so this is, you need to know about the study. Your GC can always refer patients to. So I'm planning to be a site.
Sorry, everyone. Better. Can you try one more time?
Still can't hear you too well.
What?
We still can't hear you too well.
How about no, I'm sorry, guys.
I'm gonna get my exercise.
Okay, how about now?
Oh, much better.
better. Now you're frozen.
Stephanie, we can't hear anything now.
I don't know. Let me proceed,
Oh, now.
and I can back up a little. Is it better now? You can see me? Can you hear me?
Yeah.
Yes.
Okay, so did you guys want me to back up, or did you guys kind of get
Can
a
you
sense
go
of-
back? Did you finish the microarray?
No, I didn't start that yet.
Okay, that's fine. Great. Okay, great. Thank you. Yeah,
Okay,
we can go
so
to the, yeah,
This one.
lost seek.
yeah, so ultimately, I just want to emphasize that we're not enrolling every patient that has a demise after 14 weeks or attempting to enroll them in this study. That we are going to be selective in how we approach this. But just for intents and purposes of the discussion, the inclusion criteria for the study is a demise after 14 weeks and sufficient specimen that would be available. And in this case, the cultured amniocytes is preferred. And we had that, so it just kind of lined up nicely. And then, of course, as far as exclusion criteria goes, it's really any known etiology for a demise, including aneuploidy. So we did receive the results of the microarray, and we were surprised to see that they came back consistent with mosaicism for trisomy 10, especially given the fact that karyotype was normal previously. This is a great reminder that when it comes to low-level mosaicism, that microarray has a higher sensitivity over karyotype in detecting low-level mosaicism. So in this particular case, the lab had detected about 18% of cells with the trisomy. Can you guys still hear me?
Yeah, one second, Stephanie. I want to make sure, we're coming to that. So this is really important. You're gonna see this microarray result. You need to know how to read it because on your MFM all board, they can just give you this. Okay? So what do you see here? Just look at these few letters here. Stephanie, I'm also only pointing exactly. This is all what I'm pointing for Moti.
I think this is the ARR mean array.
Oh my
Yes.
God, you need to know this. Yes.
Okay.
I am not talking to Huda.
Okay, good. ARR means array, yes. And
So
what specifically they are saying here?
10
We
chromosome
have a
10.
problem with this chromosome.
Yeah, 10. But 1 second. 1 second.
Okay.
I actually, where's the I don't know.
Oh, okay, is this,
No, but I'm thinking about now, like, shouldn't I know the number? So wouldn't before this tell you that, okay, what's the 46XY first? Shouldn't that be?
that's usually a karyotype.
But won't the, microarray tell you that? No? Okay. So then I don't know what X2 to 3
Oh wait,
means.
does that mean
So,
copies?
Okay, so
This one's tricky.
this one is really tricky. It's
I'm
not
gonna
easy.
fail now, right? Okay.
You're not gonna fail, but you may, they like mosaicism too.
No,
So-
that I understand the concept of mosaicism, but like I don't know how to read.
What you're tying, the biggest thing here to know is this number 2 to 3, okay? This number 2 to 3 means like some representation for this thing here, which is here, can be 2 or it can be 3.
3 copies?
Yes.
copies.
But why
So-
X, but what's the X for?
Times.
Oh.
Times.
Oh, I'm sorry. The X
Not the
means,
X
it's not
chromosome?
no, not X chromosome. This means times 2. So what this is telling you is,
Some cell lines had
Some-
2 to
some
3
have
times
two.
more representation of that.
no, not 2 to 3 times. Some cells have 2,
2, some have 3.
some have 3. Okay, got
So,
it?
so if you're looking at a normal microarray, the nomenclature will just say times 2, and
18% have
Moti,
three.
you're right. Right, so this is kind of, yes, exactly. So if it's normal and all cells analyzed, it'll say array, and it'll say like 22, but like in Moti, you're right, it'll have an X and a Y if it's male or female, and then it'll say times 2. And really the key takeaway there is the times 2 is normal because you're not seeing a difference in dosage. But if it's a duplication or a trisomy, you would see times 3. And then if
What if it was
a-
loss?
what do you think?
Yes.
1?
Yep,
I'm ready.
exactly.
All right.
Hold on, I'm not finished. So let's imagine another case. Remember you called me the other day for the 22Q? 22Q duplication. So here we're gonna have 22Q and they may put the genomic coordinates, but with the duplication, what will you see here? Duplication, period.
4,
Du-
3.
Wait, but first of all, why doesn't it tell you which part of the 10th chromosome?
Honey, it's the entire
It's the entire
chromosome.
10th chromosome.
Okay.
It's like a trisomy of
It's
chromosomes.
the entire chromosome. Okay, got it. So
It's
if
not like a
there's-
non-disjunction.
So the duplication case, some of you have seen her now. I've had 2 males with duplication. I can't even
Don't they
believe it.
write, like,
In like 2 months.
So it's
don't they write like dupe? Like DUP
No,
next to
they're
it?
gonna write for you he times 3.
Oh, I thought they
I'll
were
pull
right.
I'll pull it
They
up
will-
later for you
they
guys
will-
after
It will be
Clara goes.
in the analysis here, but this is always a tiny summary. Okay?
Can't it be 4 technically too? It's
Yes, of
We
course.
should
And
play
then
a
put
game
times
one
4.
day and-
If there are multiple chromosomes affected, rare. I don't
Oh, it's
know,
gonna
like,
be-
Do they just list it per chromosome, or do they like comma it? Like,
They
how
they
does
will
that-
they probably
do.
put, they will probably put commas and stuff. So yeah, it will be listed.
Can I ask a question?
Yeah,
What percentage of mosaicism do you need for the karyotype to pick it up?
yeah, that's a great question. I think at least
Yeah.
10%.
But this was 18 and it didn't pick it up.
Honey, because you it's not necessary you're having the same cells.
It
You know,
depends
they
on what
looked at.
cells you sample.
And that's why exactly what we tell patients, you never know. You know, which cells you're sampling.
So you can pick up as low as 10 on a karyotype.
I think it
Potentially.
really depends on the lab. So I'm gonna have to reach out to this particular lab and check, what is their level. We can probably, it's probably somewhere.
And you're talking, and I know this is, sorry, it's just back to the basics, only detecting mosaicism of a full like trisomy at a karyotype level, right? Technically, like of an aneuploidy.
Yeah,
That's it.
but you can
Or
detect
large,
yeah.
large solutions.
And what does this?
Exactly.
Yeah, and what does this
Why do I
stand
feel like
here?
karyotype
What does this mean here, Moti?
single nucleotide polymorphism?
So what does it mean?
It's like at the level of one nucleotide. So meaning like a mutation.
Yeah, so it's a SNP,
Like an abnormal, like a
Yeah, if
abnormal.
if someone is gonna tell you, so what type, is this an array CGH? You're gonna tell them, no, it's a SNP CGH.
Oh, I see.
Okay, so SNP looks at the tiny regions within our genomic, and then, the way they do the analysis, there's basically no control, basically here, okay?
But you can't use that for karyotype, right?
No, this is only microarray,
Yeah,
SNP is only
separate, yeah,
microarray, okay, great, that's good. Sorry we took so much of your time, Stephanie.
No worries, appreciate it. So
I'm
of
sorry, I
course, this-
interrupted you, I had to make sure, yeah.
No, of course, and I'll pull up, when Claire's done, I'll pull up a normal array, and then I'll show one with the duplication that we were talking about from before. But anyways, so really this was an interesting yet tricky result to receive because mosaicism in general is complicated. And especially in the case of a demise where you had, so far as long as we're aware, an phenotypically normal fetus. The caveat here is that, of course, we are seeing 18% of mosaicism in the cultured amniocytes that were analyzed, But that, of course, does not necessarily mean that that degree of mosaicism is the same and representative in other tissues of the fetus. When it comes to trisomy 10, we all know that this is not compatible generally with a viable pregnancy when we're talking about full trisomy in all cells. When it comes to mosaicism, the phenotype is certainly variable. Different characteristics we can expect to see is facial dysmorphism, fetal growth restriction, cardiac anomalies, brain abnormalities such as Daisy Walker malformation, skeletal abnormalities, renal anomalies, and then of course an increased risk for fetal demise. I'll be honest.
Sono though, or?
Yes.
Yeah,
Does she have
the
a
sono was
third trimester?
No.
so. It's also important to note that there isn't a ton in the published literature about mosaic trisomy 10. So the phenotype that we do have is only off of maybe about 10 cases. So here's some images of a child with mosaic trisomy 10, and you can certainly appreciate here some of the dysmorphism. You have low set ears, the ears appear to be cupped, and then the arrow here is pointing to our periauricular skin tag. And then in this image, also you can really appreciate the abnormal shape of the skull. You can see that there's shortened palpebral fissures and retronaphia here. Oops. In D, you can see that there is certainly dental anomalies with fusion of the teeth. And then in E, there is also abnormalities with pigmentation, as you can see that the pigmentation is not evenly distributed. And on the right-hand side, you can see this is actually a case report that we found where the fetus actually had clefting of the hands. You can appreciate that here, which was consistent mostly with radial agenesis. Now, when it sorry, what was that, Dr. Roman?
I just wonder what the hand looked like. Are they fused fingers or amputated fingers or?
That's a good question.
Oh,
trying
they
to
say
think back.
radial agenesis.
Yeah, so
I think they say radial agenesis.
it's completely, yeah, radial agenesis, so completely absent.
Yeah.
So at this point, the final autopsy was still pending. So we were hoping that additional information could be gleaned from that examination. And then we did counsel the family that really at this point in time, this, certainly would be a reasonable explanation for the loss. However, it's not necessarily a diagnosis that we can hang our hat on. And then also bearing in mind, she does have the APLS workup that's still pending as well. So just last week, the fetal autopsy was signed out and finalized. And unfortunately, it was not too revealing. And that is because there was significant autolytic changes that inhibited the exam. There were no obvious or apparent gross congenital anomalies. However, we did note that the fetal weight was at the 10th percentile. Microscopic examination was also unrevealing, and the placental examination was suggestive of early chorioamnitis, but this was not thought to be significant enough to be the sole cause of the demise. The pathologist was aware of the mosaic trisomy 10 results. We did share that with them to aid in their analysis, and they did not find anything overtly obvious that would suggest a truly abnormal phenotype. Their impression was that at this point in time that certainly the early chorioamnitis and the mosaic trisomy 10 could be contributing factors, but not one in particular necessarily would be the smoking gun. So that certainly made counseling a little bit of a challenge. For us, we felt that 18% of cells, even though it does seem on the lower end, is still significant enough, especially in the setting of a fetal demise. And then, of course, the SCA that was noted on autopsy could potentially fit into the abnormal phenotype that you would expect to see with mosaic trisomy 10. But again, if we had like a clear brain abnormality or something else that would point to the direction of mosaic trisomy 10, we could say with more certainty that that was likely the cause of the demise. At this point, the patient understands and recognizes the uncertainty and did actually request to still continue further workup. We, of course, mentioned that follow-up with the ATLS is important in either scenario, because, of course, there can be more than one thing going on. And then also she did want to proceed with genome sequencing with Columbia's study, just to, assess if there were any other genetic abnormalities that may have contributed to the loss. This, of course, is dependent on eligibility. So right now, she's not necessarily considered eligible for enrollment. We still have to wait for the ATLS to come back, and we did share the micro report and the autopsy report with Columbia for them to review. But if they agree with our assessment, it's likely she may not be possible to enroll, but TBD on that. So as far as counseling goes, we did tell the patient that if the mosaic trisomy 10 was truly the cause of the loss, that the likelihood of recurrence would be very low in future pregnancies. We discussed that this was likely a sporadic event, though the mechanism in which the mosaicism occurred is unknown, that either way, we would quote her age-related risk for aneuploidy in future pregnancies because she'll be AMA at that point in time. We also discussed that the availability of early diagnosis by CVS, which may be something that they may consider in the future. And yeah.
Steph, can I ask a question? And forgive me if this is dumb, but is it possible that the trisomy 10 in the placenta caused the demise, especially in the setting of like FGR?
Absolutely.
So that's yeah. So that's so okay. The specimen though was an amniocentesis for this case, so it's fetal. You got me? So we know, so which means that some of the cells of the baby does have that trisomic 10, but certainly you're absolutely right. Probably the placenta has some trisomy 10 cells. The problem is always the sampling. Like, the ideal study would be to take like multiple samples from a placenta. And, I wish I had like millions of dollars. I have many ideas, discrepancy, between fetus, between placenta. But seriously, after birth, what?
No, it's money.
Yeah, so basically, to answer it, yeah, absolutely.
I have
But
two
I think,
questions.
so I think, so I just want to tell you that I know we're presenting this case, be very careful. This is a very, very emotional couple. They were very upset at Stephanie, at me, like in the beginning, like she would say, like she wanted us to call her insurance company for payments and stuff. So she was very demanding and she was angry. So I think we just have to be very, very careful in case we see her for subsequent pregnancy. So please counsel her and be careful that we all are giving her consistent information.
Why was she upset about that? The fact that she had a problem or that
Demise.
the demise?
The loss. It was definitely a function of grief from what I gathered just spending time with her. And Huda and I both had noticed that we weren't sure how they were going to take the mosaic trisomy 10 results because, of course, it's not straightforward. And interestingly, we both had noticed the shift, and she just seems lighter. So it seems that even though that there was uncertainty, that potentially having some explanation might have helped her, and which made me think more so that this is more so grief than anything else.
Yeah, I want to up this case quickly because I also have Claire who needs to talk, and I have other things to talk importantly about this case. But go, Moti.
Just two quick, like one is there a threshold on the percentage of cells that can be any way predictive of phenotype? And then two, you mentioned you're being selective with referring cases, but for a study, isn't that going to be then selection bias? Like, why not include all eligible patients based on IUFD?
So
yeah, those are my two questions.
Yeah. So no, we consider everyone for that particular study, but the problem is, so So Moti brings up an important issue. If I have seen this patient with that, we had to send the DNA to Colombia because the cells were gonna die. Okay, so we had limited amount of time. So we told her we can do the microarray and we can send the DNA for Colombia study. Now, if I had the results for the microarray, I would not have sent her to Colombia because for me, that's an answer. The mosaic trisomy
Oh, I
10,
see.
you understand? So
Yeah.
yes, I do have to be selective.
Oh.
Now, I'm gonna be honest with you, people who do research and who have tons of money are hungry to recruit patients. So they've been calling behind our backs to reach out to this patient all the time, just to let you know. So Stephanie, can we make sure we send our anatomy ultrasound results to them also from Dr. Bolek that she signed off? Okay, great. And then,
Sure.
Percentage of.
but because they're already saying, well, you know, the baby was only 10%, and again, this is very confidential, okay? Well, the baby was only 10%, there was really not phenotypic abnormalities. Maybe that does not explain the death for the baby, and that's why they're seeking still, even though it says in the thing, trisomy, right? But what I want to make sure you guys are aware, and that's the most important thing, is typically, you're not gonna be asked this on your board, typically, the genome is not gonna pick up mosaicism, the genome sequencing.
Yeah.
Here you go. Okay, so, you know, so
Why?
why?
Yeah.
Because oh my
It's
goodness,
because
it's very difficult
Technology,
technology.
because what you're doing when you're doing genome sequencing is you're literally going through every
Yeah.
cell, right?
Yeah.
You're not gonna be able to pick up like how much of, if you notice like maybe you might know to pick up trisomy, but you're not gonna pick up like, is it in every single cell line or
Yeah.
not, you know?
So
The only
basically,
way to do that is.
unless you're a super duper expert like Dr. Berger, the person I work with at Children's National, and he has his own tools where he said he could do it. But there are very few people and very few people who would do it, especially in clinical settings. So with that said, we're gonna move to Claire Nelson. Claire, can you share your slides, dear? Stephanie, thank you for an amazing, informative, detailed presentation. I hope you guys liked it.
You, Stephanie.
My
Can you quickly
pleasure.
remind us of the name of the patient so I can look for her in the future?
What did you say, Carrie?
The name of the patient so I can make sure I catalog it for the future.
Carrie Pearl. Carrie,
Okay.
C-A-R-R-I-E, Pearl, P-E-R-R-I-L. She was
Got
a
it.
transfer to us from New York.
Korea. Mm-hmm.
Yeah, she had
Thank you.
she had her care earlier in New York before she came over to us. And now we
And
move to this third great presentation for today.
Hey, everyone can see slides, everything's good, right?
Yeah.
Okay, wonderful. I can go through this pretty quickly just for the sake of time. So congenital chloride losing diarrhea, a little background on this. It is a rare form of diarrhea that's caused by the loss of chloride and retention of bicarbonate that leads to metabolic alkalosis. It's an autosomal recessive disorder with mutations within the SLC2683 gene, and it was first described in 1945. They found over 30 different mutations, but they're still figuring out the phenotype-genotype correlation, so it's not fully studied at this point. There are, oh, sorry if you can hear someone's printing. I've got like a phantom printer that someone keeps printing to, so I apologize for that. There are over 30 different mutations, but there's founder mutations that have been observed in Arabic countries, in Finland, and in Poland. So they've actually found there's a really high incidence rate in comparison from Kuwait to Finland and Poland, and they think it's due to consanguineous relationships in that area. So we've got a nice little chart here. A 1 in 3,200 or 1 in 3,200 incidents from Kuwait. In Finland, they report 1 in 30 to 40,000, and then in Poland, 1 in 200,000.
So is it, so for you guys, is this a rare disease or it's a common disease? Rare. So how do we define rare? What's the denominator? 1 in what?
10,000?
2,000. Approximately, and this may have changed, around 2,000.
So if we're thinking about, okay, well, what would this potentially look like for an affected baby? In utero, we might see on ultrasound distended bowel loops. We might see, typically we see IUGR and polyhydramnios, just to the fact that if the baby is having watery diarrhea, that's going to add to additional liquid within the amniotic fluid. There's also abdominal distension, which sometimes could be mistaken for an obstruction. But here's an image down here that can show some distension in some loops after 25 weeks in gestation. And then at birth, there's just, of course, going to be, it is a diarrheal disorder. There's going to be watery stool, but it can be sometimes mistaken for urine. And just due to that increased volume, there's often an absence of meconium. So sometimes it can be mistaken maybe for something else that may require like incorrect surgical intervention. Other things, within the first hour of birth, if it's not known and not treated, there's going to be severe dehydration, low levels of serum, levels of chloride and sodium. And there can be some overlap between Bartter and Gittleman syndromes, which are typically like metabolic alkalosis disorders due to like exclusionary factors. So sometimes people don't receive, or affected patients don't receive the correct diagnosis right away. Some complications involved. Clearly you've got diarrhea and fecal incontinence. There can be renal involvement, such as chronic kidney disease, and this is most often seen in our patients that have delayed diagnosis, so they're not receiving the correct salt replacement, or maybe they're not complying with their treatments. Interestingly, also can lead to dental issues like pitting, enamel issues, decay, and also maybe some male subfertility, because the SLC26A3 gene is involved in some of those fertility pathways. So that was something that we didn't think about when we were counseling our female patient. One thing, in terms of treatment is just it's lifelong chloride supplementation, either as sodium or potassium chloride. There's a few other treatments out there that have been possibly suggested as treatments, but it hasn't really been proven. And clearly just like aggressive fluid supplementation when you're having, large stool output increase. Overall, though, they say it's a favorable outcome if renal complications aren't a factor. And I'm taking this as like a grain of salt, thinking about it more, from a medical standpoint, rather than maybe like a socio or like a psychologic, standpoint of, just having to be a person to have to deal with chronic diarrhea. I imagine that like brings in a whole set of psychosocial factors. But leading to our patient, we saw KM. She is a G1 P0, 16-week, 5 days at the time that we saw her. She was reportedly diagnosed with the chloride-losing diarrhea at 9 months old, so not right away after birth, and received care at CHOP and at UPenn. And of course, secondary to the CCLD, she experienced renal failure at 16 years old, received a left kidney transplant from her mom in 2012, and has a slew of other health conditions as well. She's got tertiary hyperparathyroidism due to hypercalcemia. She underwent parathyroidectomy most recently in 2022. She's got chronic hypertension and has end-stage renal disease, stage 5 now. She had not received dialysis prior to the pregnancy, and she was actually inpatient receiving daily dialysis at the time of our consult. When we reviewed the family history, there was just no genetic testing done to date. And she also reported that her sister is also affected with the CCLD, but has no renal complications like our patient did. And so as a result of that, we said, hey, we will offer you molecular confirmation of your mutations just to see what they are, offer testing for the father of the baby in case he could be a carrier as well. And of course, offered diagnostic testing with the amniocentesis with the caveat that the patient's mutations would be required in order to do that testing. After consideration, she declined all testing options, but we of course counseled her that theoretically, based on this being an autosomal recessive disorder, all of her children will be obligate carriers at the least, depending on the carrier status of her partner. And that's where we've left off with her. It's still recommended. I think she's getting dialysis 5 to 6 days a week. She just had a 20-week anatomy scan recently. The amniotic fluid levels were within normal limits, but she did have I think the baby had a slightly enlarged heart, which is not associated with the CCLD.
Yeah, there was fetal growth restriction, assuming that her dating was with what we said from Florida. The bones were measuring small, but so we thought actually that even though it subjectively looked like an enlarged heart, the thorax may be small rather than that. So we also talked to her about testing in the setting of early onset FGR, even though she has risk factors related to her dialysis, chronic hypertension, chronic kidney disease, etc. But that's interesting. But she declined.
The kidney disease, didn't she get a renal transplant?
Yeah,
She's already
she-
stage 5?
Yeah, she's in chronic failure.
So the kidney
Yeah.
transplant failed?
Yeah, I mean, she's
She doesn't, this is the one who
It's like
stays home with
chronic
blood
algae.
pressure.
Yeah, she has history of transplant that's failing.
Failing now.
Yeah.
Her
Yeah.
creatinine was 8 when she came to us.
Yeah.
She continue her pregnancy?
Oh, yeah,
Yeah.
don't ask.
And is she stay? Is she still with us? Prenatal care with us? Because I have not seen her. Oh, okay.
Claire,
Yes. Oh,
hi dear. Do you have another slide?
no, that was it.
Fine. Can you go to the prenatal, can you go to the beginning?
Yeah,
Thank you so much for
certainly.
I'm just making
It's
sure.
very interesting.
Also, of note, because we did talk about cell-free DNA with her, and we did had to do a little digging, and just as like a little side nugget in case I was unaware, that doing cell-free DNA for patients undergoing regular dialysis is not really recommended, just due to the likelihood of having sample failure due to low fetal fraction.
And I had that in the, like more
But-
than.
And also the donor sex, so that's okay. 'Cause
Yeah, so so there's multiple reasons why this woman, cell-free DNA, wouldn't be a good choice for her. And, I've had cases, so first of all, transplant patients, but then in her particular case, also the dialysis. So transplant patients alone, we can have inaccurate results, right? Because the kidney can release some cells, correct? Degraded. So the kidney patients with organ transplants, really, you shouldn't, as I could tell you, do not offer, and you need to know this for your exam too, you shouldn't offer cell-free. And then number two.
I think SMFM says that you can, but they say with that caveat,
Of
just
course,
understanding.
typically, I understand, but
What
it's
it-
not the ideal test. Yes, Claire?
And also the concern there is more so for fetal sex discrepancy, more so than anything else, or anything
Yeah.
else. And if the sex of the donor is known, that can sometimes be helpful. So in this case, the donor was the patient's mother. So I mean, I guess in theory, if a patient wasn't on regular dialysis, but knew that the sex of the fetus was, or sorry, not the sex of the fetus, that the sex of the donor was female, I think it could be reasonable to offer. But there's still uncertainties with that, with the transplanted organ.
So it's tricky, and it's a long discussion that we need to have with patients. And I think, the low fetal fraction too. Because I remember when we started to do this cell-free DNA, maybe like 10, 11 years ago, we were encountering these cases where a patient is on kidney and then low fetal fraction, and then boom, Johan Dugov presents something on this at SMFM the year afterwards. So, but the reason I came back to the slide, what do you see something here besides the FGR? You see the polyhydramnias, right? And what other, why do we think there's polyhydramnias? Probably from the chloride diarrhea, from the chloride diarrhea itself, because of all of these electrolyte changes. Claire, what was the other genetic syndrome that was in the differential, you said?
Barter and Gittleman
Barter.
syndromes.
Fetus has diarrhea.
Yep,
And they
there's
don't
more
hold
fluid.
inside.
Yeah, I get it, but I think probably because of all the electrolyte changes that happens. And
Do we
kidneys,
have hyperchloride in other organs like pulmonary secretions?
I think we have it in the GI, absolutely. That's why you have the problem with the
So it will
intestines.
be- So if we do electrolytes in amniotic fluid,
I don't know if someone have done that, but you go back to that same, can you say loudly that second syndrome? And really, I've had one case affected with that,
Oh yeah, the Gittleman syndrome.
and the other one before it.
Barter.
So you guys have to remember, so Barter is also associated with polyhydramnios. So, and the reason is because it's, I think, hypokalemic, either alkalosis or acidosis in the kidney. And so what happens is the kidneys, you keep losing the potassium. And basically, you have polyhydramnios in these cases. So, you know, that's why when we see poly, we tell patients there could be genetic disorders. I'm just trying to convince you of all of these things. With the polyhydramnios from the other ones, you know, not associated with bowel changes like this one here. So, yeah, these are fascinating cases. Thank you, Claire, and thank you, Stephanie, for
And I have
informative presentations.
I also have a copy of a report I could show you guys of a
Oh, perfect. So
normal
one
micro
second,
eye.
let Morty go. Hold on 1 second, Morty, come. No, don't move it, don't move it.
I think I
Okay,
gave it
just look
away.
here for me.
go down.
Go down. Can you go down because I'm tall.
So that's telling you that there's an array.
This is an array.
Yeah.
It examines
Chromosomes
chromosome 1 to 22,
have
and
two
there are
copies.
2, and then the X and the Y is 1.
Yeah.
Okay, that's a normal. Thanks.
I have a duplication too, if you want me to show
You're
that
gonna make me read
quickly.
an CMA.
Give them.
You
They
don't
did.
know
They
what
did
the-
give
it depends
2
on
years
the-
ago. They did.
Yeah.
I have one more for you
It's gonna
guys.
be easy for you.
Okay, great.
I'm glad we did. Okay,
It wouldn't-
it's 4 minutes before noon. Everybody have a good Thursday. And that's it.
The mock now, mock
Thank you.
exam,
Can I get my cup of coffee first?
but then I have consults.
I know.
30 minutes,
Do you
yeah.
want, how about, do you want to walk with me, getting my coffee, and then I'll start, I'm sorry. You will gain like 15-20 minutes, actually, and that's the most
You don't have,
important
you have to
thing.
have the list with you.
It doesn't matter.
I'll have the list with me. I'm gonna go print it. I'll meet you in the front.
Yes, okay. I have to.
All right, I'll meet you downstairs.
Let me go. Oh my God, he's like. I text you, Kavisha.
Yes,
Mm-hmm.
we'll reach out to Dr. Kaplan regarding the.
Yep. I can call him too if you want.